Welcome everyone. Today we will discuss an important topic in antimicrobial stewardship program implementation. Why you cannot prescribe every antibiotic you want. In simple way, why you need to restrict some antimicrobials. Restricted antimicrobials policies are not meant to limit doctors, but to protect patients, preserve antibiotics, and reduce resistance. I'm Sahar Mohammed Hisham, board certified infectious disease clinical pharmacist, UAE licensed pharmacist, and holding my clinical pharmacy master degree. So, according to the CDC core elements of the hospital antimicrobial stewardship program, there are several broad interventions. These include the prospective audit and feedback, which is point number E, also the pre-authorization, which is point number D, and even the antibiotic timeout to be held in the antimicrobial stewardship program as one of the main interventions. So, together, these strategies are used to optimize antimicrobial use. Today, we will discuss the pre-authorization and how to implement it, the obstacles on how the obstacle that you may face it when you try to implement this strategy, and how to solve it, and how to choose your restricted list, and finally, who are the person that are responsible for the approvals. So, before starting, we need to know whose antibiotics or whose antimicrobials that need to be restricted. Usually the restricted antibiotics are usually those antibiotics that carries high risk for the patient and needs to be approved before dispensing by the pharmacy. So the criteria for selecting the restricted antimicrobials may be due to the spectrum and resistant risk, where very broad spectrum are usually the last line, like carbapenems, colestins, ceftazidime, avibactams. Those usually carry a very potential risk and drive the multi-drug resistance, so they need to be used appropriately. Also, we need to restrict those antimicrobials that carry toxicity and safety concern, like colestins, because they can cause nephro or neurotoxicity, linezolide because they can cause hematological toxicity, and finally the amphotericin, which can cause nephrotoxicity. So these are the most important criteria, but also we should not neglect the cost and resources utilization. So the antimicrobial that has a very high cost, they carry a negative impact on the drug budgeting. So the antimicrobials, those antimicrobials with a high cost need to be restricted, and sometimes the patient do not need to start these antimicrobials. So from the stewardship point of view, these antimicrobials should be restricted. Also, those antimicrobials which used for a narrow clinical indications or narrow spectrum indications, like daptomycin, because daptomycin, as we know, it's usually used for MRSA bacteremia and endocarditis. Ceftriaxone tazobactam, it's usually used for multi-drug resistant pseudomonas, and not only the multi-drug resistant pseudomonas, they are used for difficult to treat pseudomonas. And finally, the echinocandins, they are used for invasive candidiasis. So if we have a certain clinical indication, you should investigate whether or not your choice for the antimicrobial will fit this narrow clinical indication. Finally, we should go through the local epidemiology, the antibiogram, and the outbreak history. Okay, so if there is a certain antimicrobial that carry resistance or shows resistance the antibiogram or in the prevalence or in the and there is an outbreak for certain in certain bacteria or certain microorganism that has resistance, this antibiotics should be restricted. Okay. Why do we need to restrict antimicrobials? We need to implement the restricted policy to preserve the last line agents, to reduce the resistance and improve patient safety, and to control the costs. So there is a universal list, there is a common list that should be implemented in your hospital, or you should tailor this list according to your resources, your local resistance pattern, and so on. The idea is that there is no single restricted list that fits all the hospital. Each hospital must implement and adopt its restricted list based on the formulary availability, local resistance pattern, scope of services, and resources. Because as we know, not all the hospitals are big hospitals. Sometimes the hospital are small or they have a very narrow scope of services. So they are dealing with certain patients with certain criteria. Also, according to the formulary availability, the hospital should not include all the medications or all the antimicrobials that need to be restricted, and also based on the local resistance pattern. It's very important to know that not all the hospitals restrict cephalosporins or restrict fluoroquinolones, but those hospitals that have a mass use for those agents, so these agents should be restricted, or even if those hospitals show an antibiogram that reveals a resistance pattern for these antimicrobials, so these antimicrobials need to be restricted. So, who approves the restricted antimicrobial? This is an area of debate. Usually, or the best scenario, it's the infectious disease specialist or the ID specialist. It's a physician, so he is being able to diagnose the patient well, to know the clinical indication, and also to communicate with the MRP peer to peer. So this will decrease the prescriber's resistance. But as we know, not all hospitals could be able to hire infectious disease specialists due to resources and due to unavailability. So a lot of hospital does not have infectious disease specialists. So who are responsible for the approval in case the infectious disease specialist is not present? According to the CDC and IDCA guidelines, they recommend that antimicrobial stewardship pharmacist or a clinical pharmacist could implement or could be hired as the one that are responsible for the approval. Okay. Also, there may be a designated physician approved by the ASP committee or the PTC committee, and those physicians may be from the internal medicine department. They are being designated to approve those antimicrobials. Sometimes due to conflict, maybe some hospital may use both agents, both personnel may uh, uh, implement a policy that needs the approval for two specialties, the designated physician according to the PTC or ASP committee, and together with the infectious disease pharmacist or the ASP pharmacist. Okay. So there is a very important point need to be addressed is the obstacles that we usually face it when we are implementing the restriction list. So maybe the prescriber feel that there is there is a fear that the prescribers um, of this restricted list cause delay for the antibiotics to be delivered to their patients. So there is a fear for delay, and also there is a prescribing resistance. So the prescriber resistance usually overcome by the implementation or hiring or by hiring someone that also a prescriber or a physician, okay, that is responsible for the approval. Also, there is a limitation in the ESP coverage. Sometimes there is a lot of beds and the persons who are responsible for approval is very limited in their number, so they cannot uh, cover all the ESP or cover all the patients. And also sometimes there is an awareness gaps. Sometimes the physician or the even the healthcare personnel do not know what is the restricted form and how to implement it and what's the meaning of the approval. And so there is sometimes a problem in the awareness. So to overcome these challenges, we need to educate the healthcare providers well on and explain them why restriction is very important, why should we always implement this strategy. We should allow also the first doses in the emergency, okay, in order to in, not to delay the delivery for these antimicrobials to the patients. Also, the hospital must develop a fast approval systems, ideally integrated in the electronic medical records, so it will decrease the time for approval. Also, finally, sharing resistant data regularly will help the prescribing to see the benefits, also to see how the restricted policy will improve the resistance pattern. Tracking outcome for the restricted antimicrobial policy is crucial. Okay, when you implement any policy or any intervention in the antimicrobial stewardship program, you should implement a KPI or key performance indicator to track your progress. So one of the most important primary tracking KPIs are to track the antimicrobial consumption. It's very important to track the consumption for the restricted antimicrobials. Also, it's very important to track the cost and the drug expenditure on those antimicrobials, and also not for those antimicrobials, also for their alternatives, because sometimes when you implement a restricted antimicrobial policy, you are restricting certain antimicrobial and their consumption and cost will decrease. But this will be reflected on other antimicrobials because the physician will shift for another antimicrobials. So you will see that the consumption will decrease for certain agents, but increase on the others. And also this will be manifested on increase at the cost as well, or the drug expenditure will not, it will increase or even be with the same. Okay, it will not decrease because the physician will shift for another classes. Also, the compliance with the policy or the adherence rate is very important to be tracked. The secondary outcomes, it's important to measure it, but it's usually secondary. It come in the come in the next step after you track the primary outcomes. The secondary outcomes, including the resistance trends for the selected restricted antimicrobials based on the antibiogram, and even to track the clinical outcomes like mortality, length of stay, or readmission. Finally, takeaway message that in our conclusion that restricted antimicrobial policy do not limit care, they protect the patients, they preserve the antibiotic, they reduce the resistance and keep the patient safe. Thank you for your attention, and I also provide a professional courses in the infectious diseases for physician, pharmacist, and other healthcare provider. These courses are available in English and in hybrid format, combining Arabic and English. In addition, I offer online consultation on how to implement the antimicrobial stewardship program efficiently within your institute. Please feel free to reach me at WhatsApp, to send me a direct message on my number. Thank you, and hope the lecture could be helpful and to be focused and to the point, and to help you to implement one of the most important and core interventions for stewardship programs. Thank you, and see you soon in the next lecture, inshallah.